Okay. With this session, we are going to do one clinical consultation session to show you, to demonstrate you what exactly they are looking for, how and why this is a skill-based examination than anything else. And I warmly welcome everyone from team PACESDIARIES.uk. Now we are going to start with our session. Okay. All right. So before I go, and I would like to know what are the doubts you guys have with PACES examination. I'm ready to address that before I just open my slides and I start telling you how to prepare for PACES examination and what exactly it is that being expected from you for the PACES examination. You guys have any doubt, you are most welcome to type it. I'm not unmuting it because all the other noises and everything will come around. All right. So that is the reason I just completely muted it and I just don't want it to be unmuted. So all of you guys can just join me anytime. All right. Like you can tell. Okay. Scare of missing positive findings. We'll come to that. We'll come to that. I'll come to the individual skills. Okay. So first we are going to start with what you should know to clear the PACES examination. Okay. Only these are the 5 things that will get you to PACES examination. Okay. All right. So couple of things. Okay. The very first thing I would suggest is like, do not worry about centers. Okay. No center has a great pass rate consistently, and no center has a great failure rate consistently. You can be rest assured of that. All right. There is a center in the West that passed 3 out of 45 candidates once. Completely, the center destroyed everybody. That was a distraction. It was like a bulldozer ride on candidates. The same center turned out to be having a pass rate of 33 out of 45. Same ways, there is a center in the south of India which consistently had a pass rate of consistently means consistently around 35 to 38 out of 45 candidates all the time, all the time, all the time. It turned out to be the center that passed just 8 out of 45. So there is no center, something called, this good center, bad center. That concept is gone because now everything is unpredictable. So all you need to do is you play your part well and you prepare and you be ready, then everything else will fall in place. That's all is going to happen. So a couple of things, 5 things that will get you through the PACES examination. First thing is planning. You need to plan. Okay, don't be lethargic. And if you have a date, just plan every day how much hour I'm going to dedicate for the study and who I'm going and what I'm going to study and how I'm going to prepare. That's very, very important. Then practice. See, this is a clinical exam. I have seen many candidates like, telling like what you are doing, I'm just reading theory. What you're doing, I'm reading theory. What you're doing, I'm reading theory. I'm not telling you shouldn't read theory. You can read theory, but it shouldn't become like you are entirely sitting with your books and reading your theory. It's not going to help you. It will just blow you out. Boom, it will blow you out. Don't do that. Don't do that. Then coming to third thing, a PACES mentor. This is very, very important. Okay, very, very important. Any candidate should have at least 2 to 3 mentors who has relevant experience in PACES. And who can afford their time for you and concentrate on you. That's very, very important. There are thousands of mentors out there. I can be a mentor, you can be a mentor, he can be a mentor. With all respect to all the mentors, the mentor should dedicate his time and should understand what exactly you need. He should be altruistic. It's what we call as altruism. What is meant by altruism? Should know what exactly you need. Different candidates have different need. I have some different need and you will have some different need. Candidate C will have some different need. So they should know what exactly they need. That is very, very important. Time, concentration, and the mentor should be altruistic. What exactly this person need, I should deliver. Then your PACES partner. I was successful in my PACES examination, got full marks, and because of my PACES partner, I would honestly till this time thank that person, thank him, because we practiced a lot, we practiced consistently, we practiced every day, we practiced like anything. So the PACES partner is very, very, very important. You should have a dedicated partner, not someone who is envy about you, not someone who is just like looking for a way to startle you or throw you out. Nothing. And above all, the fifth thing I would say is discipline. That really was a game changer in my life. I was disciplined and I was away from all the emotional stress, and even let it be my diet and let it be my, apart from diet, whatever my personal habits, everything was disciplined. And many of may think like, why this guy is talking like some kind of, moral police. It's not about moral policing. Discipline will definitely get you through in PACES examination. So these are the 5 things. With that, we are going to see how and why we need to know. All right. So any PACES examination, especially for newbies, and who are new first time going to appear for PACES examination and got a slot and just confused what to do, what not to do, there is something called a calibration. 30 to 40 minutes it can be taken for every center, every station. Okay. So what will be done here? 2 examiners will independently go. Okay. For example, a case of COPD is kept. Examiner 1 will go first, and then examiner 2 will go first. There is something called calibration sheet. Both will independently examine the patient with a COPD and write down their findings, write down the differential diagnosis, write down the clinical judgment point, what exactly they need to ask, and what exactly they should expect in that particular candidate who are going to appear for the carousel, candidates who are going to appear for the carousel. This is called calibration. So typically always remember 90% of the time, for example, if it is a respiratory station, the case kept a COPD, then a pulmonologist will not come and stand as an examiner. So don't worry. Who will be going as an examiner for a respiratory station? Your good old neurologist will go. So he is going to calibrate with the minimum basic finding. He's not going to go ahead and calibrate something like a very high level, like that of, some consultant level. So he's going to calibrate with the very basic thing. So very basic findings is what is being expected from you, just to make it very, very clear. Okay. Next thing, all the physical signs will be agreed. All the physical signs should be agreed. So the first examiner should agree with the second examiner. Okay, for example, reduced cricosternal notch distance in COPD or upgoing plantar in a neurology case. They will agree. They both should agree. If one person finds, the other person doesn't find the sign, that won't go along with that. Okay. So the calibration process, this is very, very important. You should know. Then what standard they are testing you. They are not testing you at a DM level or a CCT level, okay, or an FNB level. No, absolutely not. They are checking you at the level 3. What is level 3? Someone who can act indirectly with the indirect supervision. For example, if your consultant is not there, you are getting maybe a stroke case, you have to thrombolize, but just by indirect supervision, by having him on a call or anything. That is as per the new internal medicine curriculum UK. All right. So level 3 standard is equivalent to second year MD medicine PG. That's what I can make it very simple for you. This is the way they are expecting you. They are not expecting something you should do in subnormal level. No, nothing. Just the level 3 standards is what they are expecting from you. Next thing, these are the level descriptors. If you want to know, level 3. Level 3 is entrusted to act with indirect supervision, not the direct supervision, indirect supervision, that the trainee may provide clinical care, but the supervising physician is not physically present. Read it carefully. This is from Mrcp UK basis. That's why I'm telling you. This is the standard they are expecting from you, nothing more, nothing less. What exactly it said. Available by means of telephone or electronic media to provide advice when your consultant is not here. If he can give an advice to you via telephone or electronic media or provide any kind of advice, you should be able to go ahead and treat the patient. This is called level 3 standard. These are level descriptors. All right. So another thing, people have an issue. Okay, should I know all the DVLA guidelines? Should I remember every single thing, like, months, days, when to drive, when not to drive, every single thing should I remember? If the question is that, means no, absolutely no. You need not remember every single thing. You need not remember everything they're going to ask you in the DVLA. What PACES manual itself says? Nice guidelines or driving restrictions. The examiner must agree what is reasonable that candidates who may not live or work in the UK should be aware of. Read it. I'm not telling my own stories. I'm not telling what I believe to be true. I'm just right away reading from examiner's manual. Okay, so nice guidelines or driving restrictions, don't need to fret about that so much, so much. There are candidates, I know they're downloading all the nice guidelines, up to date guidelines, everything they want to read for every disease. No, 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 don't waste your time on that. Spend maximum time in the bedside with the patients, and sometime every day with a mentor, and sometime every day with your practicing partner. That's more than enough. All right. So they are not going to charge you, they are not going to penalize you for not knowing every single thing, every single structure about the nice guidelines. All right, just make sure of it. Okay, so these are the time and stations everyone knows. Okay, these are the thing that everyone knows. Okay, coming to this, there is a borderline judgment. If the candidate is neither to this end nor to this end, they will end up in borderline. Borderline is okay, but if too much of borderline you are going to get, then it's going to put into trouble. All right. So, okay. So the another thing I wanted to tell you is something called linked marking. What is a linked marking? Suppose you are examining a case. Maybe the diagnosis of the disease case is like, DCLD. You are not giving DCLD as a differential diagnosis. Rather, you are giving something different. You are telling it's a pancreatitis, or maybe you are telling it's an IBD. Then the differential diagnosis is gone. It's going to be marked unsatisfactory. Followed by the differential diagnosis is going to be your clinical judgment. So obviously, what they are telling is, in a simple terms, if your differential diagnosis is not right, obviously your clinical judgment is also not going to be right. So this, they will simply write link in the mark sheet. You have feedback, they will write link. This is called linked marking. This is again very, very important. All right. And another thing you should know is the thing about prompting. If you are doing exceptionally well, maybe you go and you have examined absolutely amazing, and you just picked up the sign beautifully, and you are struggling with the differential diagnosis, the examiner can prompt you, can give you, isn't it this? Isn't it that? Can you think of something else with this finding? They can prompt you. These are little help an examiner can give. But some examiner will typically write this patient, this person has been prompted, but prompting is happening during the examination. So they can prompt you. Obviously, they can. All right. That's one of the things. Then one more thing, warning I want to give you is, recently I've read a couple of feedbacks and it was really baffling. Verbal roughness is a serious failure. Verbal roughness is a serious failure. If you are going to verbally rough, verbally arrogant towards towards the surrogate, or to the, even to the patients, or in the worst case scenario, even to the examiner, they are clearly telling the examiners to award unsatisfactory from skill G. If it is given by both the examiners, it's failed. I've seen feedbacks. It's not ethical and legal to show the feedbacks in public forum like this and read. Feedbacks have been coming for some candidates like that. That particular person is verbally rough, or they use all the new English terms like Shashi Tharoor to demonstrate why verbal roughness can be really dangerous. Verbal roughness can be absolutely a scary thing. It can just generally and straightforward, it can put you down. So you can never ever be verbally rough. All right. You can never ever be verbally rough. Make sure you are not verbally rough with any candidate, any surrogates. Clearly see what is written. Surrogate can confirm that. At the end of the communication scenario, they will ask the surrogate, thumbs up or thumbs down. If the surrogate is going to be thumbs down, this guy is absolutely a bully. He's dismissing. He's not listening to me. He's misinterpreting. Or he's just keep on screaming and trying to force, being pamperishly, he's forcing his opinion on me. If the surrogate is going to tell that, you will lose the station. So never ever be verbally rough. It's very, very important thing you should learn. All right. So this is entirely a skill-based exam and nothing else. So we are going to see how to develop the skills. If you develop all the skills, you will be in no time clear the exams and you will walk in without any issues. Okay. All you need to do is you need to know to develop the skills. Now let us see how to develop the skill. The very first skill is physical examination. What they are expecting you to demonstrate correct, thorough, systematic, or focused examination in station 2 and 5. Station 2 and 5 are your clinical consultation. There you need to do focused examination. You cannot randomly check, I want to know abdomen, I want to know cardiac, I want to know respiratory, I want to know neuromuscular. Like that you cannot do. How we will do all the examination in 5 minutes, man? Cannot do that. We can never do that. That's why even in our classes, I don't one-to-one sessions and even our PACES diary sessions offline, we don't do that. We don't allow candidates to do multiple things. We just want everyone to do a focused examination. So it comes with a focused and a monitored practice. Remember, I can go anywhere and I can examine a patient and I can think what I'm doing is right, but it may not be right. What I'm doing is wrong. So that's the reason you need to have a monitored practice. And remember, you can never acquire this by watching videos or attending random PACES courses anywhere. Even if you come and attend my course also, you are not going to acquire it. You have to practice. Day to day, you have to practice, practice, practice. Take 1 week to do normal sequence. Then find patients and start doing a sequence on them. You know, it should be slick. It should be slick. Learn the basics. Practice, more practice. Even if you don't get a patient, practice on family members, relatives, or whatever patient available there. There were days during my time, it was COVID. Nothing was there. I used to practice on air, assuming there is a patient there. I just go and practice, practice, practice. Okay, always try to ask a friend, even a junior or a colleague or a ward whoever, just to watch you and just do the checklist, whether you have done everything for that particular case. People often miss I'll tell you, collapsing pulse. People miss JVP, radial delay. Sometimes lymph node goes missing, and auscultating the back in the cardiovascular system, and checking for scars in neurology, oftentimes missed or overlooked, and palpating the nerves in upper limb and lower limb can get overlooked and missed. So these are the things people oftentimes miss out. Okay, and remember always general examination, especially station 2 and 5. If you take some moment, especially in neurology, and generally see the patient itself, you will get the diagnosis. Okay, next skill is the most scariest skill that fails a lot of people across UK and as well as in international centers. Identifying physical signs. Okay, this skill needs seeing a lot of patients. I know some of you are working in a circumstance where you cannot go ahead and get all the patients in one place to see. So you guys have to invest yourself in a good PACES course. Standard good PACES course run by examiners, like, a lot of people, like, you have to go there and you have to see a lot of cases. Okay, like pass the PACES and all. You have to go and see a lot of cases there. Okay. And people, especially who are post MBBS, my sincere suggestion is, if you got a date, find out some tertiary center in your place, tertiary apex level medical institution. Go ahead and take an observership or attachment there. Okay, you need not go every day during the daytime. You may be having a job, you may be working as a medical officer, especially I'm talking to post MBBS candidates. So what you guys need to do is, you guys take the observership on attachment. That will give you access to enter the ward, especially take in departments like neurology, because you will get around 18 different cases are there in neurology. Anything can come. So with the observership or attachment in neurology, you can enter cardiology, you can see rheumatology, you can see endocrine. Please get an observership in some good campus. That's quintessential. Spend your time in the bedside. Go examine, see the case sheet, verify the findings, examine multiple times. See, identifying signs should come at a reflex level. Seeing the patient, seeing somebody's hands, what is his motor neuron disease, split hand sign, fasciculation is there, muscle wasting is there. Everything should come in a reflex level. That comes only by practice and nothing else. Okay. If there is an opportunity for you to perform under seniors, it's the best bet. They can teach you. Okay. And learn how to elicit a sign. So if you don't know the physical examination skill, then again, skill B is not going to help you. Unless you elicit it properly. A lot of people have issues with ankle jerk, issues with eliciting knee jerk. So that shouldn't be the thing here. Then remember only one thing, inventing any sort of signs is a death penalty in patients. Cases. If you are going to invent a sign which is not present there, that is going to land you in death penalty. Okay, so you have to identify the physical signs correctly. Not finding physical signs that are not present, that's going to land you in death penalty. Then skill C, clinical communication. The way you talk, prosody, your tone, your emotional component matters a lot. Many fumble due to lack of practice. Treating patient in Asia is different from in UK. UK communication matters a lot. They want you to respect the patients, respect the surrogates. You can get any kind of angry surrogate, angry patient. You should be respectful to them. It doesn't matter however they are with you. Okay, so you have to practice with a trained mentor who knows what exactly happening in cases, and they can help you. And always try to sound natural, reasonable. Every communication has a checklist. They give checklist from RCP to the examiners. This point should be there. If all these things are there, then you are a pass. You are pass. So you should know for one particular communication what are the things you should know, and do not put up any accent, please. Thinking I'm seeing a white man, a British examiner is standing, so I'm going to speak in some kind of peculiar accent. Don't do that. That's not going to help you by any means. Okay. Also, when the communication covers your history taking skills in station 2 and 5 also. So you should elicit a history relevant to patient complaints in a systematic, thorough, fluent, and professional manner. Our video on history taking skills is on YouTube. You guys can go ahead and watch it. And I have clearly mentioned how to take a history with example case as well. Okay. Know what not to tell and what to tell. All right. Okay. If you want one person who can fine tune communication skills, I would still recommend Dr. Punekar, and you can watch his videos. They are gold standard for communication. There is no doubt they are gold standard for communication. Okay. So this is about communication skills. Then comes differential diagnosis. Many people are fascinated with rare diseases. They end up telling rare differentials. In a renal transplant patient, why he is transplanted, amyloidosis. How many cases you have seen of amyloidosis in your life? Very few, hardly. And telling something rare things, like, wrong things. Somebody with a sensory finding, you go and give a differential of MND, that's going to spell trouble. And giving an LMNDD for UMN and UMNDD for an LMN, that's wrong again. Best source, BMJ1 examination, last second paces, these two I will strongly recommend. That will strongly recommend. Yes, Dr. Punekar's videos are available in YouTube. All right. So you have to create a sensible differential diagnosis for a patient that a candidate has personally accessed, not differential diagnosis randomly. For that particular patient, what is a differential? That's what. For example, somebody is coming with ankylosing spondylosis and he is having a shortness of breath. What is the cause of shortness of breath in that particular patient? You cannot randomly go ahead and tell the patient having COPD, the patient may have, ischemic heart disease. No. What is the cause of SOB in ankylosing spondylosis? You have to tell that. Can be apical fibrosis, aortic regurgitation, restrictive lung disease. That's how they are expecting you. And don't tell this, and this. Make it very simple, make it very plain. There are not lot of conditions. Very few conditions are there. Very few differentials. If you are able to tell, it's fine. Then coming to clinical judgment, I got lost in clinical judgment in communication column when I first attempted. They expect very simple thing for this. Okay. What are the investigations? You have to be specific about it, and you have to tell what exactly you will see there. For example, you are dealing with a case of multiple sclerosis. You are telling an MRI brain, just tell I will be seeing white matter lesions in this areas. I'll be expecting to see dozen fingers. And I'll be expecting to apply McDonald's criteria that there is a dissemination of these lesions in time and space. You tell that, examiners will be so happy. It means you know what exactly you are looking for. You are not randomly taking a test like a huge list package test that is being offered in India. You are not doing that. You are just going to do what exactly is needed for that patient. Okay, what RCP expects to select or negotiate a sensible, appropriate management plan for a patient, relative, or a clinical situation. You have to select appropriate investigations or treatment for a patient that the candidate has personally assessed. That is what they again telling. Personally. Personally means the patient right in front of you, what he needs. All right. So application of clinical knowledge and law of ethics, everything is needed here. Okay. Coming to managing patient concerns. See, recently I've seen a lot of people completely failing in this column. You know why? Even in station 2 and 5 and station 1 and 4 with communication, there will be a warning, 2 minutes left. When the warning of 2 minutes left is given, going and examining the patient or going and taking history, that's going to fail you because only 4 stations have the column for managing patient concerns. If you are not using your time wisely and address all the concerns, then you will be in trouble. 3 concerns at least you should address. 3 concerns will be given to the surrogate, and the surrogate will ask those concerns. You should be able to answer. Another mistake people will do here is they will give a long, lengthy explanation of the pathophysiology. Please don't do that. Make it very simple, make it very straightforward. Address them one after the other. Do not rush. Use your words wisely. If you don't know about something, be diplomatic. I will just ask the consultant and I will get back to you. Be diplomatic. All right. So what they are checking in RCP, seek, detect, acknowledge, and address patients or relatives' concern. Listen to a patient or relative, confirm their understanding of the matter under discussion, and you have to demonstrate empathy. Somebody is telling, is it a cancer? Oh, I'm really sorry that you are feeling like that. Instead of, okay, I know. Those things, don't do that. Those kind of mannerism will put you down. All right. Then patient welfare. This is very important. If you're failing here, you're gone. The exam's gone. So treat patient relative respectfully. Say thanks. And once you have just, before removing the clothes, ask permission. Once you have examined, offer to dress him up back. If he needs any help, any pain, any time, just stop the examination and ask, can I continue? Are you okay? First, before that, ask sorry for that. All right. And especially this can go wrong in some cases. There should be driving, should be stopped. If you are not stopping the driving, then again welfare will get cut. You may wondering which patient I heard. You may allow the patient to stop driving, or maybe a patient with the alcoholic liver disease, and you are not taken the alcohol history. You never offered him to stop the alcohol and refer him to Alcoholic Anonymous. Then that can affect your welfare. So it's not just about causing pain. It can cause the other way around also. All right. So this is about certain things you need to know how to prepare, what to prepare for PACES. And before you all ask, couple of things I will tell you regarding books. You don't need big books for PACES. OST, Oxford Specialty Training Series book, that is from Bilal Iqbal. Okay. And Mehta, Gautam Mehta and Bilal Iqbal, you can read the volume that is covering clinical consultation and as well as station 1, 3, and 4. Next book, Rupa Besant, Pocket Book of PACES. This is my recommendation. There are many good books out there. Okay, Pocket Book of PACES. And for differential diagnosis, last second PACES. And rider, use it for communication. This is very, very important. Use it for communication. Just know the basics. And you have to work out the last 30 communications in the last diet. You should know all this 30 communication by fingertip, because your communications are not going to come out of this. It's going to come somewhere within this. So the last 30 diet communication is very, very important. It's quintessential. All right. Any doubts till now? And what are the other doubts you guys have? Please type before we going to go ahead and start doing a case today. Somebody scared of missing positive findings, please practice, practice, practice. Make sure you spend maximum time in bedside. You will be fine. Identifying physical signs, DDs, I have told you how to do, how to come up with preparation plan. Preparation plan should be tailor-made. Please don't follow your friend's plan, that person's plan. Your situation is different. What you lacking will be different. What you need to know will be different. Sit with a mentor, ask what to do, spend and have a proper timetable. This is what I'm going to do every day. These are the things I need to read. These are the number of patients I need to see. These are the cases I need to present with my mentor. Be very, very, very clear. Choosing a mentor, just go ahead and talk to the person. Talk to the person, see his experience, how many classes he is doing, see his videos. All mentors have videos in YouTube. See whom you are comfortable with. Not everyone will be comfortable with every mentor. Some mentor can be absolutely good, but you may not be comfortable with him or her. Choose whom you are comfortable with. If you are scared to perform in a huge crowd of people, go for one-to-one mentorship initially for some days. Someone can fine-tune you. Once you fine-tune, go to the mega classes. All right. Then making DD correlating neurological signs, that we will cover in neurology differential. Already I have covered in a video that's available in YouTube. And Dr. Puneka's video, I have told. Can you repeat recommendations for theory for station 5? I already told you, doctor. OST, Rupa Besson, last second paces. Please don't spend time sitting and opening nice guidelines and reading everything in the nice guidelines for 60, 70 pages, DVLA again, sitting and memorizing everything. I just read for you from the examiner's manual. They are not expecting you to do all these things, especially international candidates. Okay. Any doubts till now, doctors? Anybody has any doubts, any clarification regarding PACES preparation? Please ask me. I'm more than happy to address that for you. Is fastest recommended? Okay, for the initial stage, I don't deny fastest is a good source. It is recommended. You can go ahead and do it. Not a problem, but not all the time. Initial stage, you can use it as a guide, but certain things which is mentioned in the past test is not appropriate. All right. Once again, I'm telling it's not appropriate. So I don't recommend those stuffs which is not appropriate. You cannot do that, right? Some things are not appropriate. Like, they're asking to pull the eyelid on their own. For example, a scleroderma patient is sitting right in front of you. She cannot do that. You cannot see the pallor in her. You have to ask permission and gently above the eyelid and so. And Indian patients, if you're just going to move your fingers left and right, up and down for the eye movement without fixing the head, his head also will turn everywhere your finger turns. So basically, you won't see where there is a restriction of eye movement, which part, nothing you will know. So that will spell trouble. Any doubts, doctor? Any other doubts before we go for a case presentation? History taking entirely I covered. These are the books you need and the equipments which you need for PACES. Please don't spend so much time buying this, fab watch and all. I don't think it is needed unless you are interested in wearing that fancy around your belt. And next, an MDF knee hammer, please buy. It's available in Amazon. Okay. Have a good stethoscope. Okay. Let it be Litman, MDF, or Welch-Allyn. Have a good stethoscope. If you have trouble choosing it, get it from your colleagues and use it on some patient and listen to your ears, which stethoscope you are feeling comfortable with. All right. Have your stethoscope with you. Have your MDF knee hammer. Number 4, please have a good fundoscope with you. Welch-Allyn or Haynes, it doesn't matter. You should have your own. because you cannot go ahead and take something randomly kept over there and press up and down in the station and waste 2 to 3 minutes of you and lose the station. You cannot. You have to have. Number 5, please have a good torch. Don't rely on center torch. There are torch with dual light in Amazon available, which can be recharged with USB, both your yellow and white light. So have a torch. So these are the couple of things you should have in your hand for PACES examination. Ophthal and dermatology is mostly covered in Rubabescent and OSD. You don't need any separate books for that. Please, no need to. Dermatology is also covered. Dermatology knowledge is not going to be extensively tested. If you are with a good mentor, they will cover up your theory. In my one-to-one session, I covered up all the theory for everyone. Skin lesion, rash, what is what are the treatment, what are the investigation. That's all you need to know. History taking, you don't need any separate book for the doctor. You should know what are the specific questions to be asked in the specific case. Please have a good mentor. He will be able to guide you. Don't waste your time on buying books and reading all at all. I would suggest reading no more than 45 minutes a day for PACES. 40 minutes is more than enough. Your maximum time should be dedicated on patients and some time with practice, especially communication and clinical consultation with a good mentor. Don't waste your time in reading theory, reading this guy's book, that guy books, and reading Harrison's and sitting and reading all the nice guidelines up to date. No, it's not needed. It will just waste your time. Any more doubts, doctors? How many months preparation of PACES from scratch? It depends, doctor. It entirely depends on you. It differs from one person to other person. And how much time you can give for the PACES examination matters. And what do you know already in medicine matters. Okay, from the scratch, 6 months, really good preparation and work is more than enough. If you are full-time preparing, 4 to 5 months, 6 months, it's more than enough. I am talking about your preparing from the scratch. Any doubts? Books, equipments, we know about centers I told. 30-diet communication, most mentors will give you, don't worry. All the online mentors, offline mentors, they will give you. They collect it from different things and you should learn it from mentors, proper mentors who have PACES experience. They will tell you what are the things to study, what are the things that's going to be asked. All right. And any more doubts, doctor? Okay. If there are no doubts, differential diagnosis, I already told you the books. Last second PACES is the decent source. If you want one more source for differential, BMJ best practice. In our course, we cover that for you. And so do most mentors have covered differentials in their courses. Okay. Any doubts, doctors? If there are no doubts, I'll just start with the case. Dr. Minam, are you there? Dr. Minam Akbar, are you there? We are going to do only one session, one case now. Especially this entire workshop is for people who are first time preparing for PACES. Dr. Minam Akbar, are you there? Not there. Okay. Who wants to? Yes, PDF version is there. It is illegal though. I can't tell where you will get it, but you will get it. Okay. Who wants to take the case? Yes. Okay. Dr. Farah, I will just unmute you. I just unmuted you. Can you hear me, Dr. Farah?
Yes, I can hear you.
Yes. Go ahead. This is your case. 5 minutes I'm giving you. Start preparing. Doctor, are you ready?
Yes.
Yes. Okay. 3, 2, 1, start.
Hi there. I'm Dr. Sadiq, one of the doctors working here in the medicine ward. Am I talking to Mr. Smith,
Yes.
41 years old?
Yes, doctor.
Okay. Today I'm here to discuss about your health issues, and I might take few notes and I will interview you and then I would examine you. Is it okay?
Yes, that's perfectly all right.
Okay. I was going through your notes and I came to know that you're having some sort of abdominal pain. Can you tell me for how long you're having this pain, this tummy pain?
Doctor, this tummy pain is there now in the last 2 days. It's very severe.
It's for the 2 days. So,
It's
okay. Did it start suddenly or was it gradual?
Hey, it has started suddenly, doctor. It's not gradual,
Okay.
it started suddenly, yeah.
Okay. Can you tell me where exactly this pain is located in your tummy?
All over my tummy, doctor.
All over your tummy. Okay.
Yes.
And does it go anywhere, like to back or to the sides? Anywhere?
I mean, it's not going anywhere, but sadly, it's all over my tummy. It's really hurting me.
Okay. If you have to rate the intensity of the pain with 0, no pain, and 10 max, where would you rate the intensity of the pain?
6 to 7.
Oh my God, that must be very upsetting for you. Okay. Can you tell me the nature of the pain? Does this pain come and goes like waves or crampy pain, or is it a sharp stabbing pain, or is it squeezing pain?
And doctor, the pain is like all over the pain, all over. I don't know what is the nature of the pain. The pain, I know. That's it.
Okay. Okay. So, is there anything which you have noticed that it makes it worst,
I don't know, doctor.
and anything which makes it better?
Maybe like I just tried taking the tablet cyclopam,
Which tablet? Sorry.
cyclopam, okay,
Okay.
and it just
Right.
gave me some relief. It doesn't give me, it didn't give me full relief, some relief.
So, is this pain remain in your tummy 24/7 at night as well, all the time?
Yeah, the pain is there all the time, doctor. There is no variation between night and day. I just try to sleep off, still it's not helping me out.
Hmm. So, do you have any previous episodes of this pain as well?
No, doctor, I don't remember having anything like that.
And is it getting worse?
Of course, it is getting worse, doctor.
Hmm. Is it associated with anything else like throwing out or feeling sick?
No, doctor, I just don't thrown out, but I am feeling sick, like I'm about to throw up.
Okay. Any loose motions associated with it?
No, doctor.
Any fever, high
No,
body temperatures?
no, no.
Is there any past medical illness you're suffering from I must be aware of?
I don't know, doctor. Nothing I'm aware of like that.
Hmm. Okay. So, is there any change in your appetite
Mm,
recently
I mean, like, not feeling like eating, doctor.
in these 2 days or for a couple of months?
Last couple of months, I don't feel like eating.
Hmm. Okay. And is there any weight changes recently?
No, no, doctor. My weight seems to be stable.
Hmm. Any lumps and bumps you have noticed in your body?
No, doctor.
Any raised body temperature or night sweats?
No, doctor.
Any change in your complexion of your face, your friends, or you have noticed that you have gotten pale?
No, 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 no. I didn't turn pale or anything so far.
Mhm. Okay. Any tiredness or, I mean, you get tired easily in these couple of months, maybe?
I am tired all the time. I'm tired. I'm weak. Yeah.
For how long?
I mean, like for some months, doctor, it's been around 3, 4 months. I've been feeling very tired.
Hmm. So, do you feel tired after doing work, or is it not associated with work? You remain tired.
I mean, like, I don't think it is associated with any work. I just remain tired.
Hmm. Okay. So, I'm going to ask some general questions from you. Do you have any discoloration of your eyes, like yellow discoloration of your eyes?
No, I haven't seen anything like yellow discoloration of my eyes.
Hmm. Okay. Any blurring of vision?
No, doctor.
Any difficulty in swallowing?
No,
Any heartburns
no,
or acidic taste in your mouth?
no, doctor.
And before this tummy pain, any other pain in your tummy? in your, I mean, any discomfort after eating food,
No, doctor.
any bloating,
No,
any
doc.
tummy swelling, any tummy swelling?
No, doctor. No, doctor.
And how about your bowel works? Is there any history of loose motions before this or hard passage of hard stools?
No, doctor. No, no.
Any passage of blood?
No, doctor. There is no passage of blood.
How about your water works? Is it okay? I mean, any decrease in amount or increase in amount?
No, doctor. No, doctor.
Any blood? Any bubbling?
No, doctor.
Any mouth sores you have noticed?
No mouth sores.
Mm-hmm. I'm sorry to ask, any sores in your private parts?
No, 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 doctor. No such things.
Okay. Any joint pains you have noticed?
No,
Any skin rashes?
no,
Any change in the color of your fingers you have noticed that getting blue, red, and then white?
no, no, no.
Any skin tightening?
No, doctor.
Any weakness in any half of your body like arms or legs?
No, doctor.
Any difficulty in walking?
No, doctor.
Any tingling or numbness?
No, doctor.
Okay. So now I would like to ask few personal questions from you. Do you smoke?
Um, Rarely, maybe 1 to 6 a day.
And for how long?
Last 10 years.
Okay, I want to tell you that any amount of smoking is injurious to health, and if you're ready to cut down, I might refer you to smoking cessation clinic. How does that sound?
Okay, doctor. That's fine.
Do you take alcohol?
Yes.
And can you tell me that for how long and how many pints in a week? How many units in a week?
I don't know about units, doctor. I just drink a small glass of vodka on the alternative days.
On alternative nights?
Yes.
Okay, alcohol is also not good for the health, and if you're ready, I can refer you to alcohol cessation clinics. Is it
Small,
okay?
small glass of vodka is too much, doctor?
I mean, any amount of alcohol.
Really? Okay, doctor.
Yeah. Are you having any high blood pressure or high blood sugar levels?
No, doctor.
Any past medical illness like heart problem?
No.
Okay. So, are you in a stable long-term relationship?
Of course, with
Married?
my wife. Yes, I'm married with my wife.
Okay. Any difficulty in maintaining intimate relationship with your wife?
No.
Okay. So, do you have kids?
Yes, I do have kids.
I'm sorry to ask, any casual partner by any chance?
Oh, no, doctor.
Okay. Any history of tattooing or party drugs?
No, doctor.
Any history of party drugs
No, doctor.
or
No,
tattooing?
doctor.
Okay.
No,
So have you gotten checked your I mean hepatitis B, C, and HIV profile?
no, doctor.
Okay. Any needle sharing?
No, doctor.
Okay. Are you using any drugs other than the painkiller you have told me?
No, doctor.
Any herbal or over-the-counter medicines?
No.
What kind of diet were you taking 2 days before this pain developed?
I mean, like normally what I used to have.
hmm No eating out, you mean to say.
Yeah, normal diet, whatever I eating. Like that's it.
So, so what do you do for your living?
Doctor, I am working in an office as an assistant.
And how this problem has affected your professional and domestic life?
It's terribly affecting, doctor. The last 2 minutes, 2 days, like severe abdominal pain and nausea is there. What can I do?
I can see that. I would definitely try to help you whatever is possible. Are you able to drive?
Yeah, I can. There's a problem with driving.
Yes, I can see that this is a very painful situation. So, did you travel anywhere recently?
No, doctor, nowhere.
Okay, any history of allergies to any food or anything, medicine you want to tell?
No, nothing like that I have.
Are you fully vaccinated against, hepatitis B and other contagious illnesses?
Yes.
Okay. Now I would like to examine the patient.
Okay, you are starting your examination at 9 minutes 40 seconds.
My goodness,
Okay,
that's too much.
have
Yeah,
just
yeah, yeah.
minutes 10 to.
Okay, okay. So I would like to have a general look of the patient. how he's built? I mean, thin built, or
Normal build.
he's normal built, or is he pale, or what?
No, he's not
Can you
big.
tell me?
Normal built adult is sitting right in front of you. You tell me what you specifically looking for. I'll show you the findings.
I want to see that whether he's having any, any pallor or any
There is
wasting.
pallor
Yeah,
plus.
pallor is present.
Yes.
Okay. And I would like to see for the eyes for any xanthelasmas, for arcus senilis.
No, nothing like that in his eyes.
Mhm. And I would like to start from his abdomen.
Okay. After pallor, seeing in the eyes, you want to start in the abdomen. Okay. Start.
Yes, I want to examine the abdomen, the shape of the abdomen,
Normal.
and okay, any distension.
No.
Okay, then I would like to do the superficial palpation for any tenderness,
No tender.
guarding, rigidity.
I mean, like no tenderness on superficial palpation.
Okay. Then after that, I would like to do the deep palpation for any visceromegaly.
He is having tenderness and there is no visceromegaly. He is having tenderness on deep palpation. Okay, you have
Where?
abdomen all over diffusely. You have 1 minute left.
Okay. So I would like to examine, I see for the bruit, any bruit there,
There
and
is
the bubble sounds.
there
And
is
bubble.
no bubble sounds. 30 seconds.
No bubble sounds.
I mean, like no bubble, abnormal bubble sounds.
Okay. And bruit?
No bruit.
Okay. And then I would like to see the hands for any clubbing or any other positive finding.
This is the
Yeah.
hands. Your time is up. You have 2 minutes left.
Okay. So what are your concerns, Mr. Smith?
What is happening to me, doctor?
Well, after examining you and after taking history, I'm thinking that you are suffering from a condition which is called as Addison's disease. In the medical term, don't bother, this medical terminology. This is basically the disease of a gland which is present on the upper surface of your kidney. And it plays a vital role in our body. It, controls various functions in the body. And when it is involved, when it functions less, you can have several, symptoms, like you can have vomiting, you can have feeling of throwing out, and you can have pain, and the skin you have on your hands, it is also dark because of decreased functioning of this gland. Are you getting me?
Yeah.
Yes, and there may be several causes that why it is functioning less. So still, but I need to confirm it by doing certain blood tests. And I would also like to involve the gland doctor in this respect. And then afterwards, once we confirm the diagnosis, then we can start the treatment.
Okay.
Any other concern?
Doctor, like, is it treatable?
Well, it is a manageable condition, and we need to see the exact cause that why it is functioning less, and then it can be managed. It cannot be cured in some situation, but it can be managed.
Okay, it can be managed. Okay, doctor.
Yeah.
Time's up.
Any other concerns you have?
Your time's up.
Okay, okay.
Over for concerns. 2 out of 3 answered. So, can you tell me your positive physical findings in this gentleman, doctor?
I couldn't see because of the short of time, but the only thing which I can see, and the rest you showed to me, so I would stick to the thing which I have seen is the blackening of the knuckles,
Okay.
and there was a diffuse tenderness in the abdomen.
Diffuse tenderness in abdomen. Can
Yeah.
you tell me, like, what are your differential diagnoses?
Well, my differential diagnosis is that it is Addison's disease because of there can be several reasons of this Addison's disease. It may be autoimmune, or it may be because of any infiltration like tuberculosis, or infection like HIV. or it can be iatrogenic Addisonian crisis, but I did not find any history of use of steroids.
Use of steroids. Okay. So can you just tell me this patient is presenting to you right in front of you in the hospital with Addison crisis, Addisonian,
Yeah,
you are getting bleeped by accidental emergency. Can you
yeah.
just elaborate what you will do as soon as you saw the patient? There is no baseline.
Uh,
What
yeah,
exactly
yeah.
the medical?
After yes, after checking the blood pressure, and if she is not maintaining blood pressure, then I would give him IV fluids and IV steroids to the patient, and might be some painkillers, and then I would check the blood sugar levels, and if they are low, I would definitely might give him some dextrose, 25%. And I would also like to, see the thyroid status before that. I mean, if I mean the tests they are available, okay. If they're not available, then I might order them T3, T4, and TSH because it often coexists with this Addison's.
Okay.
And the precipitating cause of this Addison's, if he's a known patient of Addison's, which he is not, might be there is some infection or anything which has precipitated that. I would look into the cause and I would try to remove that cause.
Okay. Okay. I'll stop here. I'll just let you know somebody asked me in a message about the group mail. Just a second. Right. Out. Coming to you, we'll go back from here. Somebody drinking an alternative diet, a small glass of vodka, is not alcoholism, or that need not be stopped unless and otherwise he has a liver damage.
Mm-hmm.
So it means they will assume that you don't know the basic units of alcohol. A small glass of vodka means 30 ml per day is permitted, up to 60 ml per day is permitted. 60 ml of hot drinks comprises 2 units. This will impact.
60 ml.
Yes.
Okay, 2 units. Yeah,
Yes.
yeah,
I
okay.
had explained everything in my YouTube video on history taking. Want
Yes.
just to post that link also here if you can carefully see everything about, especially alcohol units, where lot of people having, lot of confusion about what is this and how to deal with that. I had explained everything about alcohol,
Okay.
especially in detail. Please see that. You will have a thorough understanding. So you need not
Right.
be asking units to anyone. So this will impair the.
Okay.
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 Hepatitis B again, and hepatitis B profile. Many examiner can count it as a jargon. Better to tell a liver bug called Hep B, Hep C if it is needed. In this patient, it is not something so important to,
Yes.
because he doesn't have any high risk factor to occur such things.
Mm-hmm. Okay.
So this will be counted as a jargon in many areas. All right. That
Okay.
so what will happen here is, first thing, your communication will become borderline. They will clearly write, because jargon is one of the red flag for PACES. If you go to our PACES Diaries YouTube channel, I had just explained what are the red flags for PACES.
Yes, I have seen that.
Okay.
Yet to watch it, but I have seen the video. I mean that the topic of the video.
Yes.
I'm
Yes.
yet I'm yet to see that.
Okay. So you have to avoid jargon. Then coming to
Okay.
differential diagnosis is fine. Clinical judgment, I'll come to that. Concerns will be borderline because only 2 out of 3 concerns has been addressed. So we
Yes.
have to keep your explanation very simple. I think what exactly is happening to you is there is a gland over the kidneys. It's called adrenal gland. Don't worry about the name. It secretes a protein called cortisol. This helps in maintaining the blood pressure. And sometimes when the gland is under functions, I mean functions less, it can lead to all the things which you are having, like maybe your tummy ache, your dizziness, and all the skin changes you have in your hand, in your mouth, in your ears, everywhere. So we will just take some test right now. We will immediately admit you. We will see if that is the thing. Then we will treat you accordingly. That's it. Keep it very simple.
Okay.
You need to tell complex pathophysiologies and everything. Just one line about what's happening, one line about what you're going to do, one line about how it's going to turn up. That's all. Nothing else is needed. Okay, coming to
Okay.
physical examination and identifying physical signs. Again, this 2 will become borderline. Welfare will be okay. Here, this 2 will become borderline for one reason. Here, lot of things has missed. Lying and
Yes.
seeing blood pressure, you have to offer,
Hmm.
not offered. Seeing the pigmentation, you should offer. You have dizziness or not, that is secondary. Secondly, you didn't check the oral cavity
Hmm.
behind the ears. I'll tell you
Mm-hmm.
what exactly you need to look for behind the ears. So this will become again linked, this will become borderline. And clinical judgment, and you told investigations, but it was little haphazard. I'll tell you how exactly to approach a patient because the question was very clear. The question was on an acute setting, adrenal crisis.
Mm-hmm.
So certain things in acute settings you should be able to answer like a pro. Those are adrenal crisis, pancreatitis, upper GI bleed, stroke, myocardial infarction. I know your cardiac arrest, your air,
Hmm.
and some emergencies around 20 in number. Overall, just 20 in number. If you read them really well for your basis, you don't need to worry about NHS interview also. NHS interviews also they are going to ask similar scenarios only to you. But now it's
Mm-hmm.
have to spend time and read it really well in a way that everything should be in your fingertip to answer. Quickly, you should be able to answer. That matters a lot.
Mm-hmm.
So I will tell you how to approach that in a bit. Okay. In a bit,
Okay.
I'll to tell you. Okay, just a minute. This is pigmentation, knuckle pigmentation, which was present, which was not, which was told by you. This is the oral cavity. In this patient, you have to check the oral cavity. There's a real patient videos. See the oral cavity. There is pigmentation. There is pigmentation. There is pigmentation in the oral cavity. Next thing, there is calcification and as well as pigmentation in the ears as well. This is also a part of Addison's disease. These are the areas you need to check. If you're checking these areas, examiners will immediately know what exactly you are looking for and you know what exactly you are looking for. If that's the case, it's going to be a cakewalk for you. All right. All of you clear till now? All of it clear till now? We are going to discuss the theoretical part of Addison's disease very shortly. All of you clear till now? Absolutely clear? If all of you are absolutely clear till now, then we can go ahead and, and go ahead and learn the theory. Any doubts? No doubts are there? I'll go for the theory part of it. Okay. Adrenal crisis. We are just going to learn about adrenal crisis. Somebody typed it out. Yes. Okay. Thank you. So, how it presents? Decreased blood pressure, anorexia, nausea, vomiting, abdominal pain, fatigue, lethargy. These are all the different presentations. So precipitants, this is a question asked in PACES exam 1. What precipitates? Insufficient daily glucocorticoids or failure to intake glucocorticoid during major stress or illness, like, surgery, or somebody wants to run a marathon, or somebody is already pregnant. These are some of the major stressors of any life. So if somebody is having a major stressors, okay, then it's trouble. Should we check orthostatic hypotension in Addison? Yes, you have to offer. Nobody will give you a blood pressure sphygmomanometer to check. You have to offer. That time, the examiner will tell there is a postural drop of 25 mmHg or 30 mmHg. The examiner will tell you. You have to offer. And persistent nausea and vomiting all can precipitate the adrenal crisis. I hope the first slide is clear. Next, what are the clinical features? Okay. What are the features of primary? What are the features of primary and secondary together? See, diffuse abdominal tenderness will be there. Okay, especially on deep palpation. That's what up to date says. This is due to serositis. And increased pigmentation will be there. This has been asked again in cases due to increased ACT. H. There can be any fever due to infection. It can be a part of APS too. Okay, I said there is a pallor there. This pallor could be due to pernicious anemia. The patient may be overall having APS2, autoimmune polyendocrine syndrome 2, Hashimoto's, TTP. Okay, thrombotic, thrombocytopenic purpura. These are all the components of APS2 is a component of Addison's disease. So what are the features of both primary and secondary adrenal insufficiency? Fatigue, weight loss, GI complaints, which I told, amenorrhea can be there. and myalgia can be there, and arthralgia can be there. These are the features of both primary and secondary. The central adrenal insufficiency, central Addison's, the classical feature is they will have alabaster-like skin pigmentation. Alabaster-like skin pigmentation will be there. Okay, plus auricular cartilage calcification. See this? This is the auricular cartilage calcification. These are the signs you cannot miss. Okay, so that's very, very important. So also psychiatric manifestation is organic brain syndrome in 5 to 20% patients. They may have organic brain syndrome in Addison's. So lab abnormality, you should tell clearly. Hyponatremia I'll be looking for. Hyperkalemia I'll be looking for. These two are very, very important. Hyponatremia with hyperkalemia, that is decreased potassium, decreased sodium with increased potassium. This is something very important you should be able to tell when you are telling the investigations. And azotemia, anemia, eosinophilia, all can be a part of it. So management, how to answer a management is very important. You should be very specific. Establish IV access with a large gauge needle. Draw blood immediately. Test for serum creatinine, burn electrolytes, glucose, okay, and ACTH especially. Administer immediately 1 liter of isotonic saline or 5% dextrose in isotonic saline as quickly as possible as bolus immediately to correct the volume and maintain the blood pressure. Okay, monitor hemodynamics because shouldn't go for a volume overload with your enthusiastic correction. Then give hydrocortisone as 100 milligram IV bolus. Next thing, 100 milligram IV bolus of hydrocortisone followed by 50 milligram IV every 6th hourly. All right, this is something you are expected to tell with dosage. Provide additional support. What else you will be doing? You will give IV isotonic saline at a slower rate. Identify and treat any infectious or any other precipitating factors. Taper parental glucocorticoids over 1 to 3 days. If the underlying illness allow transitional to oral glucocorticoid. For patient with primary adrenal insufficiency, also start with mineralocorticoid replacement. Fludrocortisone 0.1 milligram by mouth. Daily 1 saline infusion is stopped. All right. Or if the hydrocortisone dose is reduced less than 40, you have to stop this. Fludrocortisone 0.1 milligram per month. So this is the management of adrenal crisis. So let it be your PACES exam, let it be your NHS interviews. If it is asked, you should be able to tell this patse without stopping at any cost. Any doubts, doctors, till now? Any doubts till now? Any doubts till now? You are more than welcome to ask me. Any doubts, doctor? There is any doubts, please let me know. You guys are more TTPS, yes, APS. As per up to date, TTP is associated. Acute scenarios, nothing much, doctor. Just cardiovascular, I told MI, your cardiac arrest, heart failure, acute heart failure. In renal, if you take AKI, that's one of the acute scenario. In endocrine, all the crises, thyrotoxic crisis, Addisonian crisis, what are the gland is there, acute pancreatitis, and abdomen, upper GI bleed, and acute fulminant liver failure. Yes, at the end of the completion of examination, or better to ask when you're checking the hands itself so that you won't forget. Not everywhere they will expect you to tell those. In this 20 acute scenarios, you should be able to tell. Because last time on stroke case came, examiner was asking about tenecteplase dose. So it's there something we should know, right? Not for everything. Nobody will ask about a chemotherapy drug use or anything. We won't get acute patients in places. What they do is the scenario will be an acute scenario where a chronic patient who is suffering from Addison's for ages will be sitting there. Nothing else. Nobody will bring an acute patient to you. No, never. Any doubts? If you guys have any doubts, you are more than welcome to ask me. All right. You are more than welcome to ask me. And you are more than it's required to give fludrocortisone if there is no orthostatic hydrocortisone able to take. Fludrocortisone is now given in primary adrenal insufficiency. After hydrocortisone, up to date recommends fludrocortisone, mineralocorticoid replacement in two conditions. One saline infusion should be stopped. After stopping it, next is if the hydrocort dose is reduced to less than 40 milligram daily, you can give. Okay. And also hypotension has to be assessed. If there is a hypotension, then you go for a mineralocorticoid along with them. Okay. Any doubts, doctors? Any more doubts? Okay. All our one-to-one sessions are filled till mid of November, and post that for December, anybody wants, you are more than welcome to join us. Would they maintain always combination of acute? Yes, exactly. They always maintain one acute and one chronic syndrome. Yes, Dr. Master. Okay. You guys are welcome to our one-to-one sessions. Okay. We cover 10, 20, 30 based on however scenarios you want. And also we have around now 20 plus faster style videos accessible to all the people who are enrolling into course. Then 35 differential videos and our textbooks. And in the 35 differential videos, we have discussed about more than 150 cases. And textbooks are available for CC and neurology. That is read only for the candidates who are enrolling in our course. You guys are most welcome to join us, but till late November, we are full. And after that, you guys are most welcome. And all our courses are UK CPD accredited courses from this month onwards. All right, doctor, you can just leave a text to me. I'll just let you know the charge. 10, 20, 30, this is different course. 10 course, you will be doing 5 clinical consultation, 5 communication, and 20, you will do 10 clinical consultation and 10 communication, and 30, you will do 15 clinical consultation and 15 communication. Right now, we are clocked at a very minimal charge, but since we are giving CPD, last second paces soft copy is somewhere posted in my group, doctor. Somebody did, and they will do. So since we are giving a CPD points, we are charging little extra because we are planning to give up to 2 CPD points per course per candidate with certificate, because we are UK CPD approved people now. PACESDIARIES is CPD approved. Yes, continuing professional development like CME, what you get in Asia, in Europe and UK, it's CPD. You can use it for your GMC or RCP and as well as your CV as well, because CPD points are valid. We can use it for anything. We are CPD accredited people. I mean, as far as I know, online, we are the only people we are doing that. CPD points you should show, you can show in your CV that you have attended and you gained this course and you have gained this CPD points, just like CME. Continuing medical education point is needed. For USMLE, US registration, you will need 50 points. In India, classically 25 points per year you have to submit. In UK, there is a regulation for CPD. So this is CPD point. All right. If there are no doubts, more, I'll just close the session. You guys are most welcome. This is done for only people who are appearing for the PACES for the first time. Next week, as usual, our clinical session will continue. And you guys are most welcome to join. Okay. All right. Take care, everyone. And you guys are most welcome. Bye-bye. See you. Thank you.